actually like the different components. So here is going to be our overview of the urinalysis. I have no disclosures, but I would like to thank Dr. Leah Hazley for providing some pictures and content that she shared with me for this talk. I asked her last minute the other day in clinic, and she was like, "Oh, okay, that's fine." So here are our learning objectives. So by the end of this talk, I want you to be able to recognize the current degree of urinalysis misuse, describe the numerous parts of the urinalysis, classify the urinalysis into 3 components for intentional systematic evaluation, interpret unfamiliar results of the urinalysis and compare their diagnostic utility, reformulate your framework for interpretation of the urinalysis, and then ultimately challenge common practice patterns for urinalysis acquisition. In order to go through this, here's kind of the layout of our presentation. And so I've blotted out some of the other parts because I don't want to give away our framework too quickly. So let's start with some background. So this is an old portrait of somebody from, I'm sure, this last millennia, some white European guy holding up a bottle of urine, looks like apple juice or brandy. And so the urinalysis was one of the first objective tests developed around 6,000 years ago. And I think also, I recently bought a copy of the Canon of Medicine by the kind of famous Ibn Sina, who is a physician and philosopher from the Islamic Golden Age. And he talks a lot about the urinalysis, urine studies. He kind of correlates them more with bad humors at that time, but it's amazing kind of seeing what they were able to connect with the urine and then actual pathology. And so I'd highly recommend everyone taking a look at that. Here is a beautiful urine wheel from, I think, 1506 in Nuremberg, Germany. So there's a lot of history of people trying to classify pathologic conditions based off of the appearance of urine. But now let's kind of switch gears and come to the now. So here's going to be our first question. So I want everybody just to kind of like take a look at this and put your answer, what you think is going on in the chat. So among patients on an inpatient general medicine service, what proportion undergo urinalysis testing on admission? Got some C's, got some D's. I think I saw a B. Wow. All right. You guys are just like so smart, such great test takers here. So it is 62%. So that is kind of like the higher end of the number, but it's not super, super high. And let's see. For our second question, of that 62%, how many of them didn't have a clear indication? C, some B's, A. Oh, wow. It's actually 84%. So when I was going through and looking at some of the epi for all of this, I became kind of like overwhelmed with like how frequently it's, yeah, exactly. Helen, I know. All right. And so to jump into some more kind of objective data for this, there was a national prevalence study which showed around 50% of admissions had UAs ordered. That's kind of similar to what we had just seen. Female sex and being a recipient of antibiotics during the admission predicted increased culture testing, regardless of the diagnosis or age. There's actually another study which showed ED admissions, about a third of them had UAs ordered without clinical indications. And there are commentaries of standing orders in nursing home facilities for UAs, things either monthly or quarterly. And depending on where your clinic is, I definitely get random urinalysis results in my inbox, also in my my in basket. I don't really understand why. So I think a big example of a systems change that contributed to increased urinalysis use was this beautiful love story between CMS and the UA with reflex culture. So this became popular when the emphasis on the catheter-associated UTI prevention kind of became included in the hospital-acquired conditions prevention program. And this resulted in the UA with reflex culture being ordered in patients who were asymptomatic. So this can obviously be a bad thing, because what are we supposed to do with culture data when somebody has no symptoms, there's no other clinical indication? I think the benefit that's come from this is that there's been a reduction in urine cultures obtained in patients without pyuria, but still. Some other issues that this can cause is, there's a lot of different components to the urinalysis. There's so many different things that you're ordering. There are different kinds of orders. In Epic, I think whenever I type in urinalysis, there are like 40 things that pop up. And so knowing actually which one to order is difficult. And so when we screen patients, even for, if we're doing a diabetes screen and we order a urinalysis as opposed to a albumin or a creatinine ratio, you can oftentimes get things that you weren't expecting. Patients with type 2 diabetes actually can have concomitant pyuria or bacteriuria, but they can be asymptomatic. And so there's nothing else to do with that. So that was the background, just to kind of set the stage for more of the talk to come. I now want to talk about a framework that I found when I was reading through all of these slides, or all the content to create this. So let's start with this. This is a familiar site. It's big, it's bulky, it's tasteless, takes up too much of your screen. You're scrolling through it when you're on the results review. I want to know from everybody in the chat, do you guys have a framework for interpreting a UA, like a systematic way? Do you know the broad components of the urinalysis? A simple yes or no is fine. Ish. I love that. So we'll go with one ish. So look for the red stuff. Yeah, I think there's a lot of people where we kind of like, we go based off of our diagnosis with the things that we're looking for. Yeah. So let's focus over here on the left side. And I'd like to introduce this framework, which is truly just how the main part of like the three main parts of the UA is. And so the first part is going to be gross evaluation, looking at color, clarity, odor. The second part is going to be a chemical analysis, which is all the stuff in here. I'm not going to read them out. And then the last part is microscopic analysis, and this includes casts, crystals, etc. So I think this is actually important to kind of know that when you're ordering a urinalysis, which usually has over 20 different tests, you should be looking at it broadly in three categories. And that's how we're actually going to frame the rest of this talk. Is I'm going to walk through each one of those, give some evidence behind them, and then we'll talk about what to do next. All right, so starting for gross evaluation, here's color and clarity. So these can present in a very wide range of conditions. There are a couple studies that look at the statistical measures of performance for color and clarity. For hydration status, which is I think sometimes how we use it, a darker urine, which was reported on a self-report scale, had okay sensitivity and negative predictive value. The specificity and positive predictive value were pretty poor. So I wouldn't recommend using those. And then I think we also, for turbidity and thinking that, oh gosh, the urine looked like there was a lot of white cells and stuff in it. This had, okay specificity and okay negative predictive value, but the sensitivity was not good. I think it was around 65.5%. So overall, since these measures of performance leave some to be desired, I think we should really view the urine as the appearance of the urine as kind of a story that our body is trying to tell us. And so I often, look back on when I treat my patients and then I get a diagnosis and I think back to when I saw their urine and be like, oh yeah, the diagnosis was kind of like screaming at me. All right, and so for the next bit that we'll talk about, this is going to be kind of a game. So these are meant to be rapid fire. So can you guys tell me what you think is going on here? Just give me a diagnosis. ATM. All right. This is actually myoglobinuria. Ooh, beads, Rashid, I like that. Concentrated hematuria. All right, what about this one? All you ICU folks, scream. I know it makes you excited. No one? Ugh. This is something called purple urine bag syndrome. I think it's so purple urine bag syndrome is actually something that's related to gram-negative organisms. I think it's different than propofol. Ooh, pubs. I didn't know that it had a nickname. What is this? Milk. Breast milk. Okay. All right. Kyler. Peachy. Oh my gosh. Peachy's so awesome. Look at it. Clinching the diagnosis. So this is chyluria. And as I was reading about this, it's kind of a milky urine that comes out, and it can happen in filarial infections. How did it get down there? Exactly. I have no idea. I couldn't find more stuff in it. And then this is actually one that Rashid got earlier. So this is bacteria. And so I show all of these like pictures of urine just to kind of help tell you that like so much is going on with our patients, but then the diagnosis really can be encapsulated in the urine. So like AIP, alkaptonuria, there's people getting B12 and methylene blue. Hematuria can be a wide range of things. And, actually this pyridium case on the left side, this is actually a woman when I was a medical student who presented to us with recurrent methemoglobinemia, and she had unintentionally been taking massive doses of pyridium, and the view of the urine was the way that we made the diagnosis. Rifampin, metronidazole, everything can change the color of the urine. So I think it's always good to take a look at the urine, especially when it's just kind of like sitting there in the ED or in the patient's room. The next part that we're going to talk about is going to be odor. So for odor, this exists on a spectrum. So urinoid, which is a normal smell of urine, can exist there or can go over to the abnormal side. This can be caused by foods, infection, metabolic disturbances, things like maple syrup urine disease. You can also have anatomic abnormalities, which are affecting this stuff, thinking about people who have fistulas and are having some sort of fecal output in their bladder. But really, odor is a big thing that we always think about, and I think that we're always told about. But what is the evidence behind it? And so I wanted to know, does a malodorous urine equal UTI? And I found a couple studies that looked at this. The first one was looking at pediatric patients, and it actually showed that for a set of patients who were admitted, they screened the parents and said, which one of these had smelly urine. Out of the 52% that had abnormal smells, only 6.4% had UTIs, and this was not significant. And then for a different patient population, folks with chronic spinal cord injury who intermittent cath, foul smelling urine had pretty poor sensitivity, but it was okay specificity and negative predictive value. I think the big picture for this for me is that I wouldn't rely super heavily on smell for infections, but again, it can kind of contribute to everything else that's going on. So that was a gross evaluation. I just want to pause for a second and ask if people had any questions before I go into the chemical analysis. All right. If any questions come up, I do have the chat going. The chemical analysis I tried to keep it big picture, so we're not going to get too much into the weeds for these things. Really just going to try to stick to what the urinalysis is going to be showing us. So the first component to talk about is the pH. So to remind everybody, the pH scale usually exists between 0 and 14, 0 being more acidic, 14 being more basic. For the urine pH, this actually ranges from 4.5 to 8, and the normal range is 5.5 to 6.5. It can usually be, slightly more acidic because of metabolic activity that's going on in the kidney, but in general should sort of correlate and move with the serum. pH can really be affected by your diet. Acidification can happen from eating increased amount of proteins. You can also get it from eating acidic fruit. High citrate diets can also cause the urine to become very alkaline. The infamous RTAs, these result in metabolic acidoses and alkaline urine. They can happen in patients, with diabetic kidney disease. So always be on the lookout for those people with the K that's going up or have overt hyperkalemia, metabolic acidosis, and then alkaline urine on pH the next time you're getting your labs. pH can also give some insight into patients with stones. I think this is an important thing for primary care. So calcium phosphate stones, calcium carbonate, and mag phosphate stones develop an alkaline urine, whereas uric acid, cysteine, and calcium oxalate stones precipitate in acidic urines. And so I don't think there's a whole lot for a generalist, I don't think there's a huge purpose for us to memorize specifically about the type of stone and the acidity or alkaline nature of the urine. But thinking about if you do get a urinalysis on somebody and it's really on one end of the spectrum or the other, kind of start to question yourself, if there's an etiology that's showing up in the urine. And then lastly, there's infectious processes. Acidic urine happens more in E. coli UTIs, can also happen in kidney tuberculosis. And then alkaline urine is more common with UTIs from urea splitting bacteria like Proteus and Pseudomonas. The next category is the specific gravity. This is something I think I was actually texting Sylvia last night, and I showed her one of my slides, and she was like, I always look at the spec grav. And I was like, oh, that's great, because I feel like I intermittently look at the spec grav. So this is going to be a ratio of the density of urine to density of water. And so whenever I think about what's going on or the things that could be changed in the spec grav, I try to think of what's going on in the numerator. So is the urine weight increasing, or is it decreasing based off of what solutes are there, or is the volume increasing or decreasing? And so that will obviously, based off of this ratio, change. And so the normal range is going to be between 1.006 and 1.027 grams per milliliter. Oh, wow. So here is, I think, a visual representation. I've isolated the volumes here so that we're just having a change in solute, but there's really a scale here that exists. So on the left side, you have a term called hyposthenuria, which is going to be a low specific gravity. And on the right side, you're going to have hypersthenuria. And in the middle, you have isosthenuria. Let's see. And so now let's kind of talk about the clinical syndromes that can come with these measurements, because I think that's the more kind of big take home point from this. For hyposthenuria, so people who are going to have low solute or likely higher volume, I think the classic example that we think about are diabetes insipidus. Without ADH, the kidneys produce these excessive amounts of urine that are not reabsorbed, sometimes 15 to 20 liters per day. But you can also have psychogenic polydipsia. GNs can also cause this. On the other end, hypersthenuria, which is going to be a higher solute or can be a lower volume or some sort of mix. Diabetes, hyperglucosuria, excessive water loss with vomiting and diarrhea, nephrosis, spilling out proteins, CHF, increased ADH release, which is like taking away your free water. And the middle range, one can either have normal kidneys or actually severe kidney dysfunction. And this can happen from AKIs and CKD. And so if you have somebody who is just like, has a nasty AKI and their spec grav is like right at 1.010, it's because they've lost their ability for both concentration and dilution. And there's also some mimics here too. So contrast media can actually cause elevated spec grav, albumin, diuretics, and antibiotics. So lots of different things here. But I think something that we commonly use it for is like what's going on with this patient's hydration status. So there are many different studies in the veterinary, nutrition, and sports literature that look into the usefulness of spec grav and hydration status. Here's a scatter plot looking at the linear relationship between urine osms and spec grav. Seems to have a pretty good fit. For those of you who want to know more about this study, it's actually of 242 urine samples obtained periodically from 20 multiparous Holstein Friesian cows from late gestation to early lactation. Really appreciate this. But I think for the clinical application for humans, like what is it really going to tell us? So there was a study that was also looking at, inadequate water intake via a spec grav of greater than or equal to 1.013. And the kind of cutoff value is like adequate hydration was urine osms less than 500. They actually found that the spec grav had pretty good sensitivity and negative predictive value, and the specificity wasn't bad either. So I think this is something that can, if you have a clinical situation that you're concerned about someone's hydration status in the setting of a normal kidney, I think that this can actually be helpful. I know the spec grav is kind of a lot. Any questions before I move on? All right. We'll quickly go through glucose because I think this is something that we're all very familiar with. So glucose is filtered and then actively reabsorbed in the proximal convoluted tubule. When the serum glucose surpasses around 180 milligrams per deciliter, the transport is overwhelmed and the excess glucose remains in the filtrate. This can happen in many conditions, most commonly the endocrinopathies like diabetes mellitus, Cushing's, thyrotoxicosis, drugs like the beautiful SGLT2 inhibitors, love them, can cause this. This can also be a sign of Fanconi syndrome or proximal convoluted tubule dysfunction. We want to think about our patients who develop this from either chemotherapy agents or people who are on tenofovir, TAF, as opposed to, or excuse me, the TDF. And then depending on the test that you use, the reduction tests, not the dipsticks, can actually give you false positives for a bunch of other sugars that are going on in the urine. Now let's talk about protein. So the normal amount of protein in the urine should be less than 150 milligrams per liter. This consists of albumin, usually less than 30 milligrams, some low molecular weight proteins, and then also TAM horsefall. Abnormal protein in the urine is going to be greater than 150 milligrams in a day. So the protein detected on the urinalysis is insensitive to non-albumin proteins, and the test usually turns positive around 300 milligrams per liter. It does not, unfortunately, detect albuminuria until 8 to 10 times the normal excretion rate. And so that's why we use other tests like the ACR or the PCR or the 24-hour urine protein. I'm not going to talk about those because that's actually a separate talk that I'm working on. I know you're all super thrilled for that. So increased urinary protein can occur, it can be a primary kidney disease, can also be a serum protein disease, and that can also be non-kidney related diseases. And I think it's nice to break these up and into the different kinds here. So glomerular protein can happen, when there's disruption in the glom, and this is usually albumin because albumin's big, is not normally filtered in a significant degree through the glom unless there's an issue. The next part is tubular protein or tubular proteinuria. So low molecular weight proteins are filtered through the glom and then usually reabsorbed by the tubules. If there's tubular dysfunction, things like beta-2 macroglobulinemia or macroglobulin and then amino acids can start to appear in the urine. Another one that I think we're always kind of very cognizant of is overflow proteinuria. And this is going to be from things like multiple myeloma. So excessive light chains are flooding the nephron and the tubules are just unable to keep up with the reabsorption. And then lastly, there's our TAM horsefall protein or uromodulin. This is made from cells in the loop of Henle, and it's the predominant urine protein in urine of healthy people. You're probably asking yourself, well, why do I see urine when none of this stuff is going on? I feel like we get those UAs and folks and they're super sick in the hospital and their UA just looks like nasty. But proteinuria can occur in a lot of different settings. So sepsis, critical illness, stones can cause it, obstruction, pyelonephritis. And then kind of the condition which I hadn't really remembered until I read about it. I think we learned about it in medical school, but orthostatic proteinuria. It's a condition that happens in 3 to 15% of young, healthy adults. It happens from standing and moving around, and then it's resolved with lying down. All right. So now let's talk about ketones. So ketones are the result of fatty acid metabolism, which mainly consists of acetoacetic acid, beta-hydroxybutyric acid, and then acetone. The first two are readily converted into acetone, and only acetone and acetoacetate are found in the urine. This happens in multiple conditions: metabolic things, diabetes, glycogen storage disease like Van Geerk's disease, altered diets, fasting, starvation, high-fat diets, anorexia, prolonged vomiting, and diarrhea. Eclampsia can also cause this. Increased metabolic states like hyperthyroidism, fevers, pregnancy, and then ultimately, of course, like stress or illness. The next section is going to talk about bilirubin and urobilinogen. I actually found this one super interesting as I was going through. So this graphic is just a outline of heme metabolism, but I want to focus you guys on this part right here. So the urinalysis measures conjugated bilirubin, which results from conversion of heme to unconjugated bilirubin in the blood, followed by conversion to conjugated bilirubin in the liver. The urinalysis that is positive for bilirubin reflects disruptions in these processes with diseases of the liver, such as hepatitis, cholestasis, and obstruction. It can also be seen in sepsis and hyperthyroidism. But of note, like a urine bilirubin should be negative in hemolytic diseases, given if there is a lack of liver disease going on. Urobilinogen is related but separate. So conjugated bile is secreted into the GI tract, where it undergoes metabolism to urobilinogen by intestinal bacteria. And after that, it's either turned into another molecule, which is secreted in stool, or it's reabsorbed to some degree back into the blood. Urobilinogen becomes positive when the liver is unable to resorb it from the portal circulation, and then it winds up in the urine. As such, urobilinogen actually detects processes which increase bilirubin production, such as hemolysis, or conditions where reabsorption in the liver is altered. And as a result, its absence can actually also signify biliary obstruction. So increased levels are associated with hemolysis, malaria, bruising, hepatitis, biliary disease, and cirrhosis, whereas decrease in absent levels, like I just said, biliary obstruction, cholelithiasis, pancreatic head cancers. Here's a table that just kind of looks at some general, like what's going to be going on with folks. So obviously in the healthy category, things should be normal and negative. In hemolytic diseases, like I just said, the urobilinogen should be increased and the urine bilirubin should be negative in the absence of liver disease. For hepatic disease, they both can be positive. And then for biliary obstruction, like I'd already said, urobilinogen should be low or absent, and then urine bilirubin should be positive. I think I was also kind of wondering about like, well, what is like kind of the diagnostic utility, the statistical measures of performance for these things? And unfortunately, urobilinogen is a very specific test, with its specificity being in the high 80s, low 90s for LFT abnormalities or predicting any serum bilirubin abnormalities, but they're not very sensitive. It's more sensitive for Billy, but it's not as good for LFTs. Let's see. All right. Next part is occult blood. This one will be quick because we all kind of, I think, probably know what's going on here. So the occult blood test is an enzymatic reaction which looks at the peroxidatic activity of both hemoglobin and myoglobin. As a result, it can either represent the presence of blood, hemoglobin, hemolysis, both in and outside of the urinary tract, and then myoglobin. If you have a microscopic evaluation that does not have RBCs, you really should be trying to figure out where it's coming from, whether that's hemolysis or there's a myoglobin false positive. Common conditions that are associated with hemoglobinuria are going to be burns, trauma, transfusion reactions, hemolytic disorders, malaria again, and then strenuous exercise or March hemolysis. And then if microscopy does have RBCs, then you need to be evaluating it manually under a scope to see if there's any dysmorphic reds. All right, now I grouped nitrite and leukoesterase. This is something I think we use pretty frequently. It's one of the first things that I look at when I see a urinalysis, just to see if there's any evidence of an infection or anything else going on. The nitrite test detects conversion of nitrate to nitrite. Many gram-negatives and some gram-positive organisms contain this mechanism. A positive result usually reflects a high number of bacteria, usually greater than 10,000 units per mil. There's a lot of varying literature, but in general, the nitrite is regarded as being highly specific and weakly sensitive for UTI. I'll show numbers in a second. And the leukoesterase just depicts the presence of neutrophils, which can be, any type of infection or inflammation going on. So the leukoesterase is regarded as being highly sensitive, but weakly specific for UTI. These data here were taken from a cross-sectional study in Tunisia in 2019, had both men and women. I think oftentimes in many different places, waiting for a urine culture is not feasible, and oftentimes people are empirically treated. And I just found that looking at these numbers really helped build my kind of like evidence-based intuition and then my clinical reasoning. So obviously, if someone has both positive nitrite and leukoesterase, it's going to be a high predictive, positive predictive value. If they're both negative, a high negative predictive value. And then everywhere else is somewhere kind of in the middle. All right. So that was all the chemical analysis. That one's like a bit dense. So what questions did you guys have before I moved on to microscopic analysis? Bueller. Is everybody loving this? I'm loving this.
I love this, Mac. I'm really excited about Urobilinogen.
Thank you so much. Like that truly is probably one of the more gratifying and like affirming things I've heard this morning. And it probably will be for like this year. All right, so let's talk about microscopic analysis. This is tough because I think you can really have multiple talks about microscopy. So I'm going to try to be big picture here. So WBCs, as we know, are reflective of inflammation and infection. Large numbers can usually, greater than 30 per high-powered field can highly suggest infection. They can really originate from anywhere in the GU tract, the kidneys, the ureters, the bladder, prostate, urethra, and they can truly be seen in all kidney disease. So UTIs, infections like tuberculosis and sterile pyuria, those two genuinely have like a loving relationship. Exercise can actually induce these as well. Malignancy, transplant rejections, AIN, glomerular nephritis. But I want to like also kind of caution you guys to not just think about the GU tract, because there's often a lot of times or conditions where you're going to get WBCs in your urine, and it's actually hinting at something else going on. So intra-abdominal infections like pancreatitis, appendicitis, other inflammatory conditions, really just be cluing yourself into taking the clinical context for things. For RBCs, I think the big picture thing to think about here is there are 3 different kinds. There's normal, crenated, and then dysmorphic, which we associate with GNs. Normal obviously have like that smooth contour, the central clearing, which should be not too much, not too little. Crenated, all of these, I think, another term is like, Burr cells for these, where you're going to have alterations in like the cellular membrane, which can happen from collection in the tubule, or not in the tubule, like collection in the tube, like too much EDTA or other things like that. And then dysmorphic reds really have these very, very prominent like Mickey Mouse appearance. Like I think this one right here is really a perfect Mickey Mouse. And so really thinking about all the different reasons the RBCs can be in the urine: infection, stones, trauma. Malignancy is always a consideration if you don't have a good explanation, and if it's isolated hematuria. And then ultimately, if someone has RBCs, I always like tell myself, like, think about a GN, be a little bit extra, prove to myself that it's not there. Next is on the list is casts and crystals, but I'm not going to really talk about casts and crystals because I really think that those are like a big talk in themselves. And I don't really think that that's a very useful bit of your time right now. But I do want to share some stuff about automated versus manual microscopy. So there are multiple studies which have looked and compared the efficacy of automated urinalysis versus manual microscopy. When evaluated by nephrologists, they're actually, they find greater numbers of renal tubular epithelial cells, granular casts, dysmorphic reds when compared to the automated UA. And, even when blinded to the history, neurologists, when doing a manual microscopy, can make a diagnosis of what's going on with the kidney in 90% of the cases, whereas if they just use the lab report, which is something that I think we're used to interfacing with more often, it's less than 20% of nephrologists can understand what's going on with the kidney. There was another study that found that granular casts were identified in 24% of automated results versus 72% of samples by nephrologists. And this is with patients with ATN. Moving away from casts, like looking at other measures of performance for WBCs, RBCs, crystals, and casts. So there's actually pretty good correlation. So R is our correlation coefficient, and P is our statistical significance. So pretty good correlation coefficient for WBCs and RBCs. Really not great for crystals or casts. Really not sensitive for pathologic casts, and I guess it's okay for the specificity for the casts. But I think this for me is something that's really important, because sometimes I try to convince myself yay or nay for a diagnosis for somebody based off of like an automated, like, the report on the microscopy on a UA result. And I just think that I wouldn't really trust that. And so that's why I recommend you should always call a nephrologist. And if people have not watched the Dr. Glaucon Flecken videos, you absolutely need to do that. So I was going to put in some cases, but I actually think I want to end a little bit early today. So, and then I also, so I removed them already. So I'll spare you guys some more active learning, and we'll just kind of move to our take-home points. So I think the urinalysis is often ordered without a clinical indication. So you really should try to consider ordering at least without a reflex culture. Our framework for the urinalysis should be 3 components: the gross evaluation, chemical, and microscopic. I want you to view the color and appearance of the urine as a way to tell your patient's story. And then manual microscopy is much, much better than automated microscopy. So always call your friendly neighborhood nephrologist. And then here are some other take-home points that you guys can kind of peruse. I wouldn't say that malodorous urine equals a UTI. If the pH is wonky, ask yourself why. Spec grav is okay for hydration status and an intact kidney. Proteinuria can be broken up into glomerular, tubular overflow, and then normal protein. Urobilinogen is a test that I have never used until recently, but it can be used to detect hemolysis and liver disease. Occult blood, hemoglobin, hematuria, myoglobin. Nitrates are specific, leukocytes are sensitive, and then WBCs and RBCs. All right. So that was my talk. Would appreciate any questions. And this was fun. Oh, I've definitely had maybe it's because I just know too many of the fellows, but I definitely have nephrologists help me spin a urine or walk me through a urine shows without actually having a formal consult. But that might be a little much on them. They're probably gonna hate me because I'm telling them that we can just abuse their time. If we see a patient in clinic for an ED follow-up and they happen to have a UA order that incidentally showed 2+ protein or some RBCs, etc., do you need to repeat this in the future? I don't actually know the evidence behind repeating. I probably would repeat it just to observe for resolution of that. I know that's been some of the practice that I've learned in my primary care clinic, is especially for RBCs or protein. We see there's a lot of pathologic conditions the body can be under, which are going to prompt those things. And so waiting till somebody's back into having some good hemostasis or not hemostasis, whatever. When their body's good, you can recheck it.
Matt, can I ask you a question about leukocyte esterase?
Yeah.
Okay, so I feel like I always actually have a hard time figuring out if the UA is consistent with infection. It seems like it'd be really obvious, but there's all these weird scenarios.
Yep.
How much do you rely on one leukocyte esterase if there's blood in the urine? Because I don't know if this is right, but I always sort of think that if there's blood in the urine and there's WBC, then there's going to be WBCs. And if there's WBCs, there's going to be leukocyte esterase. So if there's leukocyte esterase, but no bacteria, then I might just still say this is just because they have blood in the urine and it's not consistent with a UTI. If they have no nitrites, I feel like it's very specific, but leukocyte esterase, I think I have trouble interpreting sometimes.
Yeah, I agree with you. I feel like whenever I see it's positive and I don't see WBCs there, I kind of maybe look at it more as an automated urinalysis, either a poor reading or there's actually not enough WBCs in the urine to actually have shown up positive. And so I think I typically try to go by symptoms and stuff. If somebody has urinary symptoms and then there are enough signs on the UA and it's not contaminated, then I would treat them. But I don't think I have a surefire way of navigating that, other than the fact of it's really sensitive and it can definitely have false negatives or false positives. Let's see. Any thoughts on when somebody has high urobilinogen but have normal LFTs and CBC, no anemia, pursue hemolysis labs? That's a good question. I actually don't. I was thinking about this earlier, like how I would actually want to execute this, like clinically. If somebody has a positive urobilinogen, I probably would recheck it at some point, like give it a couple of days and then recheck, try to correlate clinically, and then also knowing that it could just be maybe there's like some maybe like increased reabsorption. I don't have a good answer for that. I think if there are no other signs of like hemolysis going on, and you don't have a clinical picture that fits, I would really want to be judicious with like ordering extra labs for my patients. But I think it's something that kind of adds to a diagnosis as opposed to will be something that like really points towards something being the answer. Oh, I love that. Anything else? You guys are great. I love this.
Thank you so much, Mac. This was a fantastic talk. And thank you to Sylvia and Seth as well. Really great academic half day today. Happy to see everyone on Zoom. Stay safe out there, stay warm. Yeah, all righty. See you later.